the nerve system controls this body. And if you do that first, you don't have to do anything else. I mean, chiropractic is so simple. The stupidest people in the world make the best chiropractors. Don't you realize that? That the smarter you get, the dumber you get. You know what a specialist is? A specialist is a person who knows more and more about less and less. Okay. So, and that's the only thing you have to understand about chiropractic, that it is superior to anything else. And then work to that goal. And forget the other things. There's other things that's good, but they don't have no comparison to chiropractic. I mean, you're working with the most powerful force in the world. You know, the earthquake that killed 274 people in San Francisco a few years ago, that's where it was. That's powerful force, isn't it? A force that would kill 274 people is a powerful force, isn't it? How about a guy who's adjusted 70,000 different people? That's pretty good force too, isn't it? Think. I mean, 274 people is nothing compared to 60,000 people helped. Think. So in these hands, you have more force than any hurricane, or any tornado, or anything going. You can help more people than they destroy. Okay? That's what you have to think about, is how great this thing is. And Norm Johnson, the kicker for the Atlanta Falcons, I don't think he's missed one this year, has he? You know what chiropractor corrected him? John Wissman, a guy that interned with me for about a year. He's out in Bellevue, Washington, and when Norm Johnson was the kicker for the Seattle Seahawks, he was injured. If he would have kicked one more field goal, they would have won one more game and been tied for they would have got into the playoffs. If he would have kicked two more field goals, they would have won their division. So he had a PI. Right ileum was all his problem was. And John corrected him. Now the next year they thought he wasn't going to be any good. And they brought in another kicker who worked for $100,000 and Norm was getting paid $300,000. With spring training or whatever training they go to, he kicked a 54-yard field goal. But so did the young guy. The young guy matched him kick for kick. So guess who they kept? Kept a younger guy that was kicking just as good for less money. And Norm Johnson came down here. And I don't know what he did last week, but I know up till now, this year, he's been perfect. Up to last week. I think he had 17 for 17. He had the best streak going for a long, long time. And he was given up on. But he was helped chiropractically. And he done a tape for us on visualization. Bragging about this machine. Because these big promoters out on the West Coast were going to promote the visualizer. And they were going to be so good to me. They were going to do all the sales and give me $500 for each one. But they had all these tapes made and everything, and I didn't think that was such a good deal. But you can correct ligaments, you can correct anything. See? If you adjust the right vertebra. Now this is the motion. If you have that motion, you can get in a whiplash injury. See, the atlas controls everything. If you have a good atlas that's moving, your structure will be so good that you won't even whiplash. It would have to be a real severe accident for you to whiplash. See, my son's had a perfect neck all of his life. He totaled 5 cars and never whiplashed one time. Has a perfect spine, and it moves perfect. When I was looking for this motion, I looked everywhere, and here he was right next to me. So it's his neck that I use as the perfect, and it's his neck that has movement. Now this kid, the only symptoms he ever had in his life was schoolitis. And there's only one correction for schoolitis, and it's not a chiropractic adjustment. It's the whine of the school bus motor fading out of sight. Immediately. I'm hungry, Dad. Do you think I can have something to eat? I thought you were sick. Oh, no. Feeling a lot better. Well, then I think after we give you something to eat, maybe we ought to drive you on to school then. What do you think about that? Schoolitis. And chiropractic is the only symptom a chiropractic can help. Now that's the perfect spine right there. That's how it should flex. Just like that. And that's how it should extend. Now, of course, when we drew this picture, we weren't in IVFs. We didn't know about them at the time. They should be closed down. Closed shut is what they should be in extension. And the spinuses should close down. And the line should be curved. So see, you're looking at three things. You're looking for bodies at your line measurements. You're looking for IVFs, you're looking for spinuses. Of course, spinuses are easy. They're slits, they open, and they close. The holes are slits, they open, and they close. That's all you have to remember. Now that's a flex neck. How many lines does it take to touch this neck? 3 lines. It should be one curved line. We have 3 straight lines. We're in trouble. We're in severe trouble. Now on this neck, besides having a kinking down, see, here's our kink down. We have a kink up. See, this is a kink down. This is a kink up. Now forget this part because you'll get confused. See the difference? A kink down, the rain would slide off. A kink up, it would hold rain. The water would be in here. That's all you have to remember. Now, a kinking down, the subluxation's right below the kink. Whenever you have a kinking up, the subluxation's above. It's above the kink. Now, when it kinks down, it's the one directly below the kink. When it kinks up, it could be any of them. Now I'll show you how to figure this out. I'll show you how to figure out which one it is. It's easy to figure out the kinking down, isn't it? What number is it? What's the subluxation on the one kinking down? 6. That's easy. You got that one down pat. Now we got to put a bunch of rules together to find out which one it is kinking up. See? Now forget what view we're in. Is that a good occiput atlas axis relationship? Huh? Is this spaces even? Take the picture and put him back up into a flex, just a regular neck. Is that a good occiput atlas axis relationship? The answer is yes. Certainly it is. They're even, aren't they? If it's a good flat lateral picture, can it possibly be a good flexion picture? Huh. Forget what you see here. This hole's closed. If that hole's closed, then that means what's the axis doing? Huh? It's stuck. It didn't move. Because if the axis moved, we should have a big hole there. It hasn't moved. So what vertebra do we know subluxated then? Axis is subluxated. Okay, if this space didn't change, what vertebra do we know subluxated? And we call the occiput a vertebra. So if this space here doesn't change, this space controls axis, what space does this control? Occiput. This space should move what? 1 unit away from the axis. So if it's the same as it was here, and it stays the same here, what vertebra do we know needs adjusted now? The axis. What else? The occiput. And then the atlas is supposed to move towards the occiput, isn't it? Did it do that? No. So how many subluxations do we know we have from this one picture?
At least 3.
4. You already gave me the 6th. Now you give me the occiput, you gave me the axis and the atlas. That's four vertebrae that are not moving. None of them are moving.
If C2 doesn't move, doesn't that control occiput and atlas? So
No. If C2 moved, they'd both move with it. But occiput can move away from axis. Yeah. Now the atlas probably would still be subluxated, but the occiput can definitely move. That movement is independent of the axis. It moves away from the axis. So that movement is controlled by the occiput all by itself. See? The occiput moves away from third. Who controls that movement? C2 controls any distance that occiput moves from third is controlled half by C2. 50%. Because it'll move 2 units away. It'll move the same number of units away from 3 as it does from 2. The occiput. Okay. The occiput will move 1 unit away from axis. It'll move 2 units away from third. Because it moves 1 with axis. Anybody want to tell me what's subluxated here? This is what type of kink this is? Kinking up or down? It's kinking up. See, we go across here with a straight line. And then we go up with a straight line. So we have a kinking up right here, in here. We have a hole here. We have any holes here? Who controls all these holes? Huh? Axis controls every damn one of them. So if there's any subluxations down there, what? We can't see them because the axis is the rolling subluxation here. So the axis is definitely locked. What else is locked here? Atlas and they're all locked, aren't they? Usually when one of them are locked, they'll all be locked. And all you have to do is if you can lay your flexion over your flat lateral, they're all locked. They have to be totally different. You have to keep in mind that every aspect of a flat lateral, a flexion and extension has to change on all 3 pictures. All of them. And if there's one part that doesn't, that's the part you're in trouble with. Now, what other part of the cervical spine usually can be laid over top of each other, Kenny Guzik? Where's the other big trouble? See, he didn't think he'd get a question. He's back there thinking, daydreaming.
I'm thinking
and
about trying to capture you inside this
I
view
got
over
him.
here. Repeat the
Okay.
question.
Huh?
Repeat the question.
What other part of the cervical spine is often repeatable in flat lateral and especially extension?
Flat lateral, especially.
Yeah, what part of the cervical spine? Oftentimes looks
Because it's a problem.
because there's a subluxation.
T1.
Huh?
T1 area.
T1, C6, C7, and T1. You'll have spread spinuses on the flat lateral. They'll be spread in flexion, and they'll be spread in extension. Okay? They'll look exactly the same.
How are you actually doing the say, the flexion shot? Is it like this, or like this, or like this? You know?
It's this. Tuck your chin in. That's your occiput atlas axis movement. Take your head down. 2 movements.
Is that supposed to be a flexion?
That person is flexion.
It seems right in here.
Well, she can't flex. She can't flex. She's subluxated. She's like this. This woman's like this, looking at you in flexion. She can't do this. So I call the turkey neck. You take them down, they're still looking. This type of person, when they flex, they want to flex from the waist, see? Just can't put their head down. So it's tuck your chin in, take your head down. That's the 2 steps. And once they're down here, as soon as they start going back, now if you have motion, you don't do that if you don't have motion. You say, lift your chin up immediately. Get that chin up. Because once you start back like this, if you don't have your occiput moving, it'll bind. I mean, before we were doing this right, we had a lot of occipits locked in extension, didn't we? But there's more occipits locked in flexion than there is in extension. Why isn't there as many extension locks? You know why? There's more flexion locks than there is extension. What is an extension, really, of the neck? You know, all the muscles that control the neck are in the back. There are no muscles here that control anything in the neck. No muscles here. So when you extend the neck, what are you doing to the muscles, ligaments, and tendons? They're relaxing. So they don't have to do any work. That's why there's less locks in extension. The most locks are in flexion. Almost all the locks are in flexion. Especially up here. See, this is your bad flexion locks up here. Extension locks are minor. Extension locks are easier to correct because it's much easier to tell a person to relax than it is to get all ready for a fight. There's that same neck that I gave you the first picture of that had 3 lines on it. Look at that miserable neck. Now we have arthritis in the 6th, the 7th, and the 5th, and probably first dorsal. Now, some of you have had a lot of seminars before. How many years do we know this person's had that subluxation? 20 to 25 years. 5 years for every arthritic vertebra. Is that a good occiput atlas axis relationship? It would be good if it was what picture? If it was a flat neutral lateral, it would be a great picture, wouldn't it? So we have kind of locks here, don't we? And see, if you have that many locks in flexion, and you have that type of arthritis down the lower, you're probably going to find 6th, 7th, and 1st locked in extension. So this neck has about 6 subluxations in it. Now, if it has 6 subluxations, then keep in mind each one of them vertebrae are affecting its mate. So if we have an occiput atlas axis and 6 cervical locks. Now look at this. Occiput atlas axis and 6 cervical we know is locked. Now keep this in mind. Every lock affects the vertebra above and below it, plus its mate. So let's see how many vertebrae are affected here. The occiput's locked. What's its mate? T3. What's the vertebra below it? C1. C1's locked. What's its mate? T2, what the vertebra above and below it? Occiput and axis. Axis is locked. What's its mate? T1. We're up to 6 right now. 6 cervical is locked. What's its mate? C4. We have 8 vertebrae involved out of 11. Now, you want to get some more? 6 cervical is locked. It affects the one above it and the one below it. Now we have 10 vertebrae. Which one are we missing here? C4 is the only one that we're missing out of the whole 11. Okay? Now, this person then going to come in and want to know if 2 adjustments will get them well. Okay? That's how much trouble they have. And we know for sure, let's see how many years they've been sick. If an atlas is locked like that, you can bet it's been subluxated since the day they were born. We know that the 6 cervical's been there at least 20 to 25 years. See? And if we have a 6 cervical subluxation, what usually goes with a 6 cervical subluxation? What other vertebrae? C4 is its mate. C3. And if C3 is subluxated, then what vertebra width will affect? The one we missed, huh? C4. and axis. So we really have every vertebra in the cervical spine affected because its mate is affected or its neighbor is affected. Okay? So you have all 11 vertebrae, which includes the occiput, affected in this patient. This is why you have to sit down and explain to patients how sick they are. And then you give them a choice. You either want corrected or you don't. If you want corrected, you're going to have to listen to me. See, but people's heard this so long from chiropractors, it's hard to make them understand.
This guy's seen him 3 times a week, call him the same
Yes,
words you use.
absolutely. But see, what the difference is that I have all my pre and post pictures documented, and here they are. This person was under chiropractor's care for 7 years. This is after 2 months of my care. Suit yourself. Doesn't matter to me. I mean, it's a constant defense. If I could change my title in the morning to another profession, I'd be most happy to do it.
I know you need more criteria, but like, for example, this patient here, where would you start on the adjustments?
On this patient, the first adjustment should be at 6 cervical, because this is her acute subluxation. This is the subluxation that's causing her the pain. It's the one that came, this woman is quite old. That subluxation came after she's 24 years old. These subluxations came way before that. You always start with the acute subluxation. And the acute subluxation is the one that's going to give you relief of pain. Like I say now, we're talking about acute in a whole different sense. That subluxation is one that came after the age of, maybe we should change that name to a different thing, but it came after the age of 24. There's a 3rd cervical subluxation. Very seldom do you get a 3rd cervical subluxation locked in flexion. They are almost always locked in extension. Now let's look at this. Now there isn't any, but let's pretend. If there's hypermobility in this spine, where is it? Right? But you know why that appears to be hypermobile? Because all of this is hypomobile. Now, when third cervical subluxated, always keep in mind that first dorsal is also, not first dorsal, axis. See, when axis is locked, third's locked. When third's locked, axis is locked. But it depends on what you see. What they're like, the best way I can explain to you axis and third, they're like a double door, you know? Like if you had two doors there, one of them's locked and the other one's just stuck. They're both locked, but you have to unlock one to get the other one open. Well, that's what an axis and third subluxation is like. And the only way you can tell which one you want to adjust is by looking at the IVF. Now, if the IVF is closed on flexion, which one do you think you wanted to adjust? C2. And if the IVF is open on extension, which one would you want to adjust? C3. Now you understand, whenever you're looking at motion, you have to look at three things. What vertebra are moving? What vertebra are not moving? And what vertebra have already moved? Now see, when a vertebra is already moved, it can be locked there. See? Like you go outside here, you move. If I lock the door, you ain't come back in. See? You understand? I go out that door and you pull that door shut. I had full freedom of movement. But now you're not letting me come back. So that's what happened when axis and third is in trouble. Picture them like a double door. If one of them's locked, it'll lock the other one. But you have to know which one has the key. So the way you tell is by flexion and extension. If this hole doesn't open up on flexion, axis is your key. If it doesn't close up in extension, third cervical is your key.
I'm missing, why would you do that? It's over.
Look, if the axis is already moved, and it doesn't come back in extension, it's because third's not letting it. Okay? And to adjust axis, you would tear the ligaments. Axis is already moved as far as it can move. And there's a big hole there. You always have to have some place to move a vertebra. Axis always has some place to move because its normal motion does what? Moves everything above it anyhow, doesn't it? So if axis is locked and you adjust it, what's going to happen to everything above it? They're going to move. Are they going to start moving? No. They are going to be moved. They are not moving, but they were moved. That's a difference. Now, if axis is already moved and you start pounding on it, you're only going to hurt the patient. But if that door's open, there's no sense in me going over here and banging it on this side, is there? I have to either go on the other side and pound it, or I've got to go underneath and move the thing into it. And that's what you do. You never have to adjust axis and third at the same time. One of them will unlock both. But keep in mind that if axis is locked in the normal position, it's an axis adjustment. If axis is already moved, then it's a third cervical adjustment. You understand that? But you're picking them up in different places. Now, if axis is already moved, what would the normal flat lateral picture give you? It'd give you a big hole. Then you know you don't have to adjust axis because it's already moved as far as it can move. You're going to adjust, huh? Pardon me? They come through. Now see, there is, and that's the x-ray of that patient. The subluxation on that is between axis and third. There's a first cervical subluxation. Now these are drawings over regular x-rays. Now you can see where B is there. It looks like there is a lot of movement there. But the only reason these people palpate things and call hypermobility is because it's opposed by hypomobility. Once you put, see what this vertebra below is doing, it's using all the mobility of all the other vertebrae. It's like it's using their gas. Now once you start their motors up, they're going to move back down and reclaim the gauze strip down there. You know, they're going to reclaim their space. Right now, and people want to monkey around with hypermobile joints. You should go to bed every night and pray to God that every joint in your spine has hypermobility. Did you ever see these acrobats? That they can bend down to where and put their head between their ankles? That's what you call hypermobility. I want to tell you something about that. Very seldom we ever find a subluxation on it. But when they quit exercising, then they subluxate. Yeah. You get these kids in, they'll have kyphotic necks and they won't have one subluxated vertebra. But they have extended their joints so far that they'll look like they have a horrible spine. But let them quit exercising. And then them vertebrae will lock up so fast it's unreal. That's why these athletes and stuff should be checked on a very, very regular basis. Fifth cervical. Now there's a fifth cervical subluxation. That is a fifth cervical subluxation. How many years old, Ursula, is this subluxation?
25.
About 20 to 25 years old. Okay? What vertebra are we guaranteed from this x-ray is not subluxated? Ken? We know that there's one vertebra here that is definitely not subluxated. Only one. There's only one that we can be absolutely positive of. Is definitely not subluxated.
Not subluxated.
Not subluxated.
C1.
No, the C1 is definitely subluxated.
I'm not saying.
C1 is definitely subluxated, isn't it, people? Because this is a good flat lateral picture, so it's definitely not a good a flexion picture.
This is a flat lateral?
This is a flexion.
I was gonna say.
But what I'm saying, the occiput atlas axis on this picture, that's what it should look like in a flat lateral. So if it's a good flat lateral picture, it certainly can't be a good flexion picture. So we know the occiput and atlas is locked here, right? What vertebra that we know for sure is not locked? C2 is definitely not locked. Why do we know that? Because you can walk through that hole between them. See? You can walk right through this hole. That means that axis is already slid forward as far as it can move. And of course we have the 1 unit of movement here. So how far has the occiput moved so far on this patient? 1 unit. How did it get there? Riding with axis. How far has atlas moved, Rick? 1 unit. How did it get there? A road by axis. Yeah,
But you asked which one isn't subluxation?
that's what I said.
You said C2,
Yep,
because it's already moved as
it's
far as.
already
it can go.
moved. So if it's already moved, we know we can't move it any farther. Now, would we suspect that C3 is locked in extension? I'd say no. Because if we have a C5 subluxation, very seldomly we have a C3. Okay? Not only that, if we had a C3 subluxation, where should the posterior arch of atlas be? If it was it should be up against the occiput, shouldn't it? Okay? See? You start putting these rules together, you'll learn something. There's a C6 subluxation. What other reason do we know we have a problem here, Laura? C6. What else do we have here? We have arthritis. So just looking at that picture there, how old would we say our subluxation is? Yeah, or maybe 15 to 20 because there's arthritis on 5-2. Always give yourself the extra one. Count the vertebra and always throw one in for good measure. See, because it's coming, you just can't see it yet. So when you say between 15 and 20, it could be 16. Okay? So you're not going to see anything. But you'll be surprised how many times you hit it right to the minute. One time down in Florida, when I was trying to build what I'm building here, I was trying to build in Florida. And I had a bunch of rich people for patients because they were trying to help me. My problem was I couldn't get any chiropractors to help me. And I couldn't get a license down there either. That was another reason. But I could have got a license if I would have did what they wanted me to do. Okay? But I'm like some other people I know, I'm hard-headed. Whenever you want me to do things that I can't do, I'm not going to pretend I know how. See? I mean, because I don't believe I should be required to adjust feet. Now, I know how to adjust feet. But in my office, if there's anyone else there that knows how to adjust feet, guess who adjusts them? I can adjust ankles, I can adjust knees, I can adjust anything. But usually, see, I never took any courses. So when I have someone who just come out of school and they have all these extremity courses, I'll say, I can remember one time a guy come in and the name was George Stankus, had a sprained ankle. And I had Kathy with me at that time, that picture of the girl there. I said, Kathy, adjust George's ankle. So she monkeyed around with it for 15 minutes, and then she told him to go home and put heat on it and cold on it. And he just looked at me and he said, but Doc, I want to go golfing. I said, take your shoe back off, George. Set the cuboid. He got up and walked out. The cuboid is the fifth cervical of the foot. The sacrum is the fifth cervical of the pelvis. And of course, the fifth cervical is the fifth cervical of the neck. See? So, if you know how to adjust the cuboid, you can correct ankles like that. And it'll also adjust the talus when you set the cuboid. But they didn't know that. But how could I pass when they failed me on a PI radiolium and I invented the move? They failed me on that one because they didn't know how I was doing it. So that made it wrong. Whenever you see three lines like this, what you have is you usually have one locked on flexion and the other one locked on extension. See? So this one would be locked on flexion. See, you can almost tell by a spine how it's going to break. And what I mean by breaking is where the kinking point will come. this is breaking here. When it goes back, it's going to break in the same spot. So on extension, it's the second vertebra below the kink. So if this is going to kink back here, this is going to be our lock. So you have a rule that goes for the mid-cervicals. Just the mid-cervicals. What are the mid-cervicals? 4, 5, and 6 are your mid-cervicals. So if you have a lock, one of them in flexion and one of them in extension, the rule says adjust the lowest of the two locks. So if you had one locked in flexion and one locked in extension, you would adjust the lowest lock. And that rule only applies to 4th, 5th, and 6th. When it gets below that, the rule changes. This is the old extension rule. In extension, it is the second vertebra below the kink. You see what I'm trying to read? He's working. He worked down there. He worked, didn't you, John? You tell Diane we'll be putting rock glass up pretty soon. I need her to come up and hold it up.
Roof on the roof, rock on the roof, I don't care.
Okay. But when I do rock glass, and I like Diane better than you. Okay? So you send her up. She hold, no, you stay home. Now we have a new extension rule. The new extension rule says it's the second vertebra below the kink, provided that the spinous rule and the IVF rule agrees. So in other words, this vertebra here, which is 2 below the kink, the spinous should stick out and stand alone, and you should have a big opening above it. When you're doing adjustments for locks and extension, you should always have a space to move it to. And that would be a big IVF above the subluxation. So if you don't have a place to move it to, look to the next lower vertebra that has all criteria. Now usually in extension, you will find, on a real bad lock, you will find 6th, 7th, and 1st all locked in extension. And what you would do here, when you have that many locks in extension, the holes will be like this. And the spinuses will all have spaces between them, but just like the holes, there will be more spaces equal with the holes. So that means that first dorsal is the big problem. But if you have all 3 like that, you should never try to pull in cervical spines by adjusting dorsals. Because the dorsals has something that cervical spine doesn't have. And what's that? Ribs. Now, if you try adjusting an older person, you have to be real careful because you can break ribs very, very easily. There's hardly a chiropractor in this world who adjusts dorsal vertebra that hasn't broken a rib at some time in his life. Especially with those double transverse contacts. All the adjusting we do in the dorsal spine is done on the spinous, unless there's rotation. And if there's rotation, then it's done on the high transverse side. But when we do that type of adjusting, we use instruments for that adjusting. Now remember, in the mid-cervicals, if there's a couple locks, you adjust the lowest one. In the lower cervicals and upper dorsals, you would take the lesser of the evil, the middle of the evil, and the evil, in that order. So you'd work 6th cervical, 7th cervical, 1st dorsal. An A to P cervical, all spinuses should be connected by one straight line. Why don't you take a break? Divide in half, and you know you want 7.5 on each side. So if we take 2.5 off of 10 and put it over here, we'll have 7.5 on both sides. You got that? You, my puttier, my painter. You got that? That's my painter. I'll tell you what, she might not paint as good as the guy, but I like her better. I think you paint better. John's wife is my rock clapper. She holds it up, why nail it up? Doesn't she, John? You want to tell him how she holds it up? She holds it up with her bust. I lay it on there, and she holds it there like that. Doesn't she, John? Isn't that the story? You gonna tell on me? You gonna tell on me? Big tattletale.
I got it on tape.
I guess this situation was.
I'll tell Kenny's wife on him what me and him did one time down in Georgia. Watch how fast it comes off the tape now.
What tape are you talking about?
Watch it come off the tape now. You got that? Okay, now we're going to divide the head in half. Just take the ruler, turn it sideways, and put it on this stuff. You see there's a line there. That's actually cut in half, but now I'm going to put the line there permanently. There it is. We put the line there. Now you can measure the axis. The guy with the earring. What's your name? Did you know what's coming? Been waiting? Joe. Okay, Joey. Give me an axis listing here. Hey! Hey! Maybe you ought to put an earring in his ear. He got one in his nose. All of us married guys got one in our nose. I'm the boss in my house. I have my wife's permission to say so. Entire segment left. Does everyone see how he got that? Okay. You, university over there. Whatever. If the body was in the center and the spinus is right, what would we list it as?
Spinus right.
Okay. If the spinus was in the middle and the body's left, how would we list it? Oh, boy. Smart group. Okay, now. You know how to pick the rotation from looking at the A to P? Oh, you need Laura? I need Laura too. I need you too. Hi, Vicky Boo. Good. Does anyone know how to pick up the rotation of the atlas from this one?
We put triangle right close to it.
Yes. This would be these triangle-shaped things he's talking about. It's the lateral masses that hang below the posterior arch. You know, this is the only question on the Florida board that was chiropractic. What's this line? I was afraid to put posterior arch. I was so sure that he wanted chiropractic question. Is that the posterior arch, or is that one of those things? Yeah, that was the only question on the board that was chiropractic. A posterior arch of atlas.
That's where your 13 points came from.
Oh, no. On x-ray it was written. No one could fail me on a written exam. I made 97 on that. And on the law, I made 87. So I passed the two written parts. They got me on practical. asking me who Babinski was. I said, it's a Polack name. And Lavost, Patre, or whatever it is. I said, some Frenchman. The only one I remember is Valsal was tested. I got that down. Now my question for you, Harold, is if I dirty my pants, would that be considered positive or negative? I don't know. They're either positive or negative, so my question to you, if I dirtied my pants, would it be positive or negative? Absolutely! But if I hadn't went to the bathroom for 3 days, what would it be to me? Positive. So see, negative, positive. Depends on the circumstances, right? Depends on who you're standing next to. Okay, we look at this posterior arch, and we look at this little triangle thing. And the lesser amount is on the side of anterior rotation. The greater amount is on the side of posterior rotation. Okay? What do you mean, no? You're talking about Gonstead. This is Pierce. This is Palmer. I know what they say. They say measure this here. And the bigger one is the side of anterior rotation. The smaller one is the side of posterior rotation. That's because it's closer to the filling. That's why that would exist. But that's too hard to look at that way. This is much, much easier. Because they can't be rotated that much to make those lateral masses look that much bigger.
So what distances are you measuring?
It's just a little triangle.
Between the bottom of the...
Yeah, between the bottom and the arch. The tip of the mass, the lateral mass, and the arch. Okay, see there, we're pointing them out to you, those little triangles. Now, of course, the base posterior would verify that for you. The greater angle is on the side of posterior rotation. The lesser angle is on the side of anterior rotation. That's the base posterior shot. Now, we can have vector intersections on A to P's too. You can have 2, sometimes 3 vector intersections. You can have rotation. So you have all kinds of things. Now the secret of this is you want to line everything up before you adjust them. So whenever you have this existing, you will take your headpiece and do what we call 3D. Almost all the time, when you have an intersection like this, that cross will fall on the vertebra that's the most posterior. So when you have a kink this way, you'll usually have a kink this way. Now, the first kink is this one. Then you start this. Then you start this. So see, it's just grades of degeneration. Now, if you can get a person when they're strictly posterior, fast correction. As you start getting tilts and rotation into them, more time. See, you don't ever get 2 patients in the same state of degeneration. That's why, like people say, well, how long does it take? You don't know that. Because everyone's different. Everybody responds different. So the secret of this is, you want to take out the posteriority. If you had head tilt, take that out first. If you had rotation, take that out second. You do that by the table. Then adjust for posteriority, and when you do that, then you take out everything. The secret of adjusting is to get all the pressure off of a person's neck before you adjust them. So we do that, we call this 3D, and we call this circumduction. And we'll show you how to do that on the table. This is rotation without head tilt. You can have vertebra rotating without having the head tilted. So you would just use circumduction on this patient, then take out the posterior. The axis spinus is the worst vertebra for being misaligned but not subluxated. The axis is the pivot point. So a lot of times one of the lower vertebrae will pull the axis spinus out of line. And you can pound and pound away on that axis spinus and not get anywhere. And then you adjust one of the lower vertebrae and it'll pull that spinus right back in line. And one of the vertebrae that will do that real easy is which one? The mate of axis is what? T1. T1 will bring that axis back in line. The arthritic rule. The most arthritic joint is usually the subluxation. It spreads to the vertebra below, then the one above, and then below. 5 years for every level. In other words, if the fifth cervical gets subluxated, and here's the fifth cervical right here. If it gets subluxated, it will affect the lower part of the subluxation and the top of the vertebra below. Then it'll move up to the top and the bottom, and then it'll move down and up the spine until it gets the entire spine. So if you look at a spine and there's 5 vertebrae with arthritis in it, go to the middle. If there's 4 vertebrae with arthritis, you would go to the one above the middle. There's no middle to 4, so you cut them in half. It'd be the one above. If there's 3 vertebrae, it's the middle. So if there's an odd number vertebra, it's the middle vertebra. If it's an even number vertebra, it's the one above. If the arthritis just started, there would only be 2 vertebrae. So you cut them in half, and it's the one above the middle. It's either the middle vertebra or the one above. Now there can be 2 arthritic rules in the same neck. Now if we have 2 arthritic rules in the same neck, which 2 do you think they'd be? There can only be arthritis between 2 subluxations in the neck. And which 2 do you think it'd be? 3 and 6. Because if you have arthritis at 5, you usually don't have a 3rd cervical subluxation. If you do have arthritis at 5 and you have a 3rd cervical subluxation, which one came first? 5. Because if you have a C3 first, that throws the spine out of compensation. And once the spine is out of compensation, you cannot have normal compensation of the 5th cervical. It has to be 6. See, so you have to understand that if the 5th is out of line, it was first. If 6th is out of line, it was second. And 3rd was first. Now, arthritis will spread like this if it's on 5th or 6th. It will never spread this way from 3rd. Arthritis on 3rd will spread to 4th and totally destroy the whole joint there. I mean, it'll flatten down and you'll get spurs as big as your finger. But very seldom does arthritis move to axis. Why would you think that, Dr. Shade?
Because it's the most movable?
Atlas and axis are the most movable vertebrae even in the lock stage. So you very seldom get action on a busy street. Grass don't go on a busy street. Who told him that?
Nobody. I know.
You got that on your own.
Yeah. Well, they are the most movable.
Richard's research is
Yeah.
done on this stuff.
You answered the question.
I actually got it right and I was awake.
I think Lori's been quizzing you.
No,
I didn't say anything.
it's the other way around.
This is where we found the arthritic rule. This is a patient of mine that came to me in 1974. And I adjusted the atlas vertebra because at that time I was doing most of the upper cervical. Is that atlas out of line according to how we think today? Is those spaces even, or is there more space at the top? Spaces aren't even, are they? Okay, so we adjusted the atlas. We totally ignored this arthritis down here. I want to